started. So welcome everyone to our Fall Child Welfare Dialogue. As many of you know, as part of the Title IV Child Welfare Training Program, we're able to bring in speakers who are doing exciting and innovative things in child welfare and have them talk with our students and also invite our community partners as well. So this is our fall series, and I would just appreciate everybody coming today. I also just want to throw out there, if for those of you who are working in the community or also our students, if you have ideas about who's doing innovative practice and new and exciting things, feel free to contact me and let me know who you've seen out there, and we can see if we can bring other people in. So thank you for that. I am going to read everyone's bio today, and then I'll have them add anything additional in that you want, just so that you can know who we have here today. We have 3 presenters with us today, and I so appreciate them taking the time out of their semesters to come and talk with us. So we have Gabe McGaughey, who is the Director of Wellbeing for Children's Hospital of Milwaukee Community Services and is a founding co-director for the Institute of Child and Family Wellbeing, and you're going to hear a lot more about that today. He's worked in child welfare for a long time, trying to move the field towards a more holistic approach to working with children with the goal of meeting their developmental needs to support long-term success. Before being the co-director of the Institute, he led the Child Welfare Case Management Program at Children's Hospital. Some of you may know him from there. And he has a bachelor's and a master's degree of social work from UW-Madison. Everyone here today is a Badger.
Go Badgers!
Yeah. Next we have Josh Mersky. He's an associate professor at the Helen Bader School of Social Welfare at the University of Wisconsin-Milwaukee and is a founding co-director of the Institute for Child and Family Wellbeing. His research interests include the study of childhood adversity, trauma, and resilience. Dr. Mersky is dedicated to translating evidence into practice and policy applications, particularly within the context of early childhood and 2-generation families. Among his current projects, Dr. Mersky heads the evaluation of Wisconsin's Family Foundation's home visiting program, which supports evidence-based home visiting statewide. He is also a co-investigator on the statewide investigation of alternative response programs in child welfare. And Dimitri Topitzes was a clinical social worker for Waukesha County's Department of Health and Human Services for a number of years, before assuming a full-time faculty position also at the University of Wisconsin-Milwaukee, where he currently serves as an associate professor of social work. Over the course of his academic career, he has conducted research on the long-term effects of child maltreatment, trauma, and interventions aimed at preventing or treating early trauma. In his role as an educator, he teaches courses on trauma counseling to master's level students and founded the Trauma-Informed Care Graduate Certificate at UW-Milwaukee. Recently, he helped co-found the Institute of Child and Family Wellbeing, for which he serves as the Director of Clinical Services. So we invited them all here today because, well, A, they're all Badgers, yay. It's wonderful to see our alum come back and impart all of the knowledge that they've learned since leaving here. But also, these are really great people who are really passionate about providing research and direct practice services and doing policy advocacy that will really help move the needle and make lives better for the kids and the families that we really care about. So welcome. Thank you for coming.
Thank you. Thanks for having us. So I think I'm going to be the one who gets us going here. Just by show of hands, how many folks are from the community in here, just so I have a sense? And I'm safe to assume everybody else is students? Okay. Oh, no. I know. She's placed with us, actually. It's always nice to come talk to students. It's one of those weird times where really you're the ones who are supposed to replace us in 15 to 20 years. So it's nice to meet you. We'll talk today a little bit about our journeys and our work, and feel free to ask questions at any point in time. But I think we'll have time at the end to answer questions too. And hopefully we'll be able to answer all of your questions. So my name's Gabe McGaughey. I've been with Children's Hospital. Came here after I graduated to be a case manager in the case management program. I had interest in program evaluation and ended up doing quality improvement and data analytics at Children's before moving into the role of director of the Child Welfare Case Management Program. And in that program, you really take a big step. In that role, I really took we were working hard and really understanding and doing the best work we could. We really tried to set up a program that didn't strive for good, but really just tried to be excellent. And when of course, we have to understand the work that we do in the context of ASFA, the Adoption Safe Families Act, which set up, as everybody here knows, back in '97, set kind of the three goals that we still look at in terms of safety, permanency, and well-being. And one of the things that I kind of struggled with when I was in that role was, we have actually seen a great number of great improvements both in terms of safety and permanency and child welfare since the Adoption Safe Families Act. There's lots of different strategies to address these two issues. And well-being was always one that for me was undefined and therefore you ignore. Because you didn't want it to be a judgmental or a personal judgment thing. Well-being, you didn't want it to be like, well, a foster home can provide ballet classes or whatever, therefore the kid should stay there because they have X, Y, Z kind of opportunities that they may not have with a family, and you didn't want it to become a thing about poverty. So really for the majority of my career, I was like, well-being, not really well-defined, certainly not measured. Let's pretty much ignore it because it was just a sand trap of potential, I think, well-intended but maybe missed opportunities. But at the same time, you see some of the numbers here, safety and permanency, we've seen great decreases since the mid-'90s. That was in the number of kids in foster care. You see permanencies go up, you see timely permanency improve. Safety, kids in foster care are probably less likely to be maltreated than kids in the general population. So there's a lot of things that have gone on, and if you work in a jurisdiction that struggles with safety or permanency, there's lots of resources out there. There's lots of research, and then lots of things that kind of really reflect the growth in knowledge because federal government set up these goals and standards. And then they, of course, set up the Child and Family Service Review process that went about measuring and helping us understand these. And of course, you see this slightly old data. We saw a brief uptick probably, but it's starting to come down again in caseloads. But Wisconsin's kind of middle of the road. But if you want to learn more about how to see declines in caseloads, look at some of the other jurisdictions. Look at DC. There's lots of examples and lots of information about different ways to look at permanency and get kids to permanency in a new manner. But well-being was kind of neglected. And one of the things that back in '08, Brian Samuels was the Commissioner for Administration for Children, Youth, and Families, and really kind of worked to define well-being and put it in the context of child development, adverse childhood experiences, and understanding child functioning as a new goal as opposed to just looking at safety and permanence. Because if you look at especially permanence, which gets a lot of, and this is, I think this slide, I'm not going to read it to anybody, but we'll make them available. Really, just because a child achieves permanency doesn't mean the child's better. So what is our real standard for success? Is it having smaller foster care systems? Or is it for kids to be better off? So well-being really started to shift the focus away from just safety and permanency, which, this quote you'll see everywhere now in a lot of federal and a lot of policy literature around child welfare, necessary but not sufficient to ensure around the work in child welfare. And you see kids, the research is done, sometimes, kids who are reunified aren't better off down the road. Kinship care and adoption, there's lots of challenges post-permanency. And if you look at here in Wisconsin, we actually have a pretty high reentry rate as well. So I think our reentry rate's somewhere around 20% statewide. The goal is 9.9%. So is it good to have a smaller foster care system if your kids aren't doing any better? So it's really our work around well-being, and when we start really looking at well-being in the context of child development, which, by the way, you can measure, it is objective, you can look at, there's tools out there that can help you understand both child functioning the trauma that they've experienced and the trauma symptoms, as well as parent functioning, right? So if you look at in the history of the child welfare and how we measure and what we look at in the data that we collect, it's all about kids. There was up until recently, and this is I think still being rolled out, there's 5 things in AFCAR's data, which is the federal data source for child welfare data, that were about parents, which included name, race, ethnicity, gender, and date of birth. So that's all we really knew about parents and child welfare, and there's been a lot of work. The current ACOF commissioners talked about co-occurring disorders, and we've been looking at some of the same things, and there's a widespread acknowledgement that the data on parents is just lacking. It's not good information. So, kids aren't necessarily better off after they leave care. We don't know anything about their parents and their function, their issues. And we can now really start, especially even since I graduated, if you look at what we know about brain science and work done by the Harvard Center for the Developing Child, these guys and a number of other folks, we understand what happens with a child's brain and functioning far better, and the adults, by the way, far better than we did when I graduated. We used to do stuff that now would make me cringe. And so, I think as we talk today, one of the things that I think, if nothing else, you take away from this is that need for continual evolution. In my experience, we've really seen that there's no jurisdiction out there that has all the answers. So when you go out into the field and say, all right, hey, how do you do this, or what's this, and you're going to find answers that are well-intentioned and best guesses, but nobody has all of them. And so that constant learning and not leaving academia too far behind you, I think is going to be really important, because that's the partnership, one of the things I value with the partnership with these gentlemen is really that kind of that continuous learning and leveraging the research and translating that into practice. And so how do we start, child welfare and nonprofits in general? You can talk to, I've seen this, it's everywhere. They count services. It's often, I work at Children's Hospital, they count things too, because that's usually how people get paid. So when you start looking at, all right, how many times did you see a kid? How many times how many kids do you work with? All those things can be tied to payment. So does that, how many times did they have a parent-child visit, parent-child interaction? How long have they been in foster care? These are all process things that you can measure. But really, looking at the well-being stuff are the trauma symptoms reduced? Did the increases in services, are their coping strategies better? And that's really changing the bar and raising it to the next level for, I think really it's going to be the challenge for the 21st century, that's a huge shift. It's a huge paradigm shift, and we're not currently set up to answer those questions outside of research. And so that's one of the things that one of the reasons collaborations like this are so important, because figuring that out there's no canned manual for it, and it's going to be an evolution. I certainly don't have all the answers today. But we can talk a little bit about how we approach some of the work. And again, this just goes back to, from a program and systems perspective, how do you start descaling the transition to this new shift is, how do you stop doing things that don't work and start doing things that you do? And there's a lot of barriers to that. So just because you say, hey, PCIT is great, and you're going to learn a lot about PCIT today, but there's the one PCIT trainer in the state of Wisconsin. How do you actually bring these things to your jurisdictions? How do you work with the constraints of the training? So we're kind of at a crossroads in terms of understanding, hey, these things are better. And one of the ironies and the things that I think we want to do with the Institute is shorten the time frame from understanding when something's better to implementation. Because PCIT has actually been around since, the 70s? Mm-hmm. And these guys brought it to Milwaukee and Wisconsin in a meaningful way back in, 2009? 11? Mm-hmm. That's a little bit of time. So how can we shorten that time frame to start bringing more things that matter, and more things that we know have evidence that support impact to the field faster? So when I talk about well-being, really one of the this is the definition Schultz comes up with. If you look in there's been a lot of great push, and it's widely recognized that this captures the spirit of the definition of well-being, but the federal government still doesn't define it. And one of the reasons, fascinatingly enough, is they actually want to get something done. If you look at trying to define things at the federal government level, look at how long it took them to define what a homeless child is. And I would argue they didn't do a perfect job of that either. So this isn't the definition of well-being isn't memorialized, and the measures for well-being at the federal level are still lacking as well. So there's definitely some things that still need to be done to make sure that policy supports new practice and drives practice in a good way, much like you've seen with the setting the standards around safety and permanency have changed over time. The first standards around permanency have radically changed, and they've changed at different kinds of measures through research and collections and feedback from the practice side, saying what's realistic and what's not, and what are they seeing in terms of struggles and challenges, and how do you look at all these things in a new and different way. And so safety and permanence have had a lot of evolutionary steps, and we just need to take one step here with well-being, hopefully sometime soon. So the ASYF did parse out a systems approach to well-being, which was looking at breaking it down into really simple three steps: assessment of functioning and development, use evidence-based interventions, and monitor progress and impact of the interventions at the child and family level. It's a pre and post test, right? It's not rocket science. But at the same point in time, it's easy. It's simple. It's 3 steps. Trying to do this on a population level is extraordinarily challenging. We don't have any data in Wisconsin. Well, we do, but we don't have. The state doesn't have any data that captures this progress over time. The CANS tool that if you haven't been trained on, you will be at some point, probably. The way it's used in Wisconsin doesn't really lend itself to it because they don't want to see change because they don't want to because of how it's tied to the foster care rate. So you really got to be the CANS. It's not my favorite tool anyway, but it's something that it's like, all right, it maybe gets the assessing and functional development. It doesn't necessarily help you understand change over time adequately. So that's one of those things where when I talk to our friends at the states, like, we could change that, but changing how you pay foster parents is a big thing. But that's the 3 core steps. So as we're looking at these things, it's like, all right, how do we do this, and how do we operationalize it? And we really started concurrent. We had, and this will take us to the institute. So as I'm sitting at this place of saying, all right, how do we assess? How do we get access to what evidence-based interventions are even available in the community? How do we do all this? We actually had a few 4E students who were at UW-Milwaukee return from their 4E program back to work in the agency, and they were trained in parent-child interaction therapy. PCIT is a great therapy, and you're going to hear a lot more about it. So I'm not going to get into all the details of it, but it's great for child welfare because it's well researched in child welfare. It's really effective. It's time limited too. So when you're working in child welfare, one of the things that you're always cognizant, you should always be talking to your families about is timelines, right? You got to know where you're at in the timelines, and you need service providers and services that can work within those timelines. So working with a parenting program that goes on for 52 weeks or something like that really doesn't necessarily fit the ASFA timelines. And so I really saw the opportunity with the students coming back like, ooh, PCIT, it fits a lot of our needs. It's well validated for our families. And then as we were talking to the students, we reached out to Josh and Dimitri and said, hey, how do we do this? How do we actually take this and take part of the work that they've done in their Project Connect, which is actually a randomized control study that they did, which is a group-based adaptation of PCIT, which is great, which is talked about more later. And that's where we started having these conversations of like, and really identified that shared value between the academic and the practice of we were working on the same thing, just in different buckets. And how do we start? And we both liked and needed to cross over to this and the policy side. So that's kind of where we started talking about PCIT and assessments and child welfare, to kind of go back to, all right, we understand assessments, here's some evidence-based interventions, and then how do we actually monitor for progress a little bit. So this is kind of a little bit more of our current state. So we actually established a well-being assessment program at Children's. So, excuse me. So every first-time entry family entering foster care for the first time gets assessed by one of our 4 MSW clinicians in training, who gets supervised by Dr. Topitzes. And really, we spend, it's a structured interview format that is focused on using evidence-based tools to engage, motivate, and understand what's going on with the families that they're working with. So we look at things along the lines, we spend, so for the kids, we do a functional assessment and a trauma screen. Excuse me, functional assessment, a trauma screen. So we understand where they're at developmentally. We use the ages and stages questionnaire for our 0 to 5 kids. We use we look at reading levels for our middle-aged kids, and then we actually looked at protective factors for our adolescents, recognizing that each of those developmental stages has different things that are probably that are worth emphasizing. Mm-hmm. And then we do a trauma screen throughout, but and we use that to help complete the cans. But one of the things, most of our time is actually spent with parents. So as opposed to having those 5 demographic pieces of information about parents, we actually spend probably a good 5-6 hours with parents,
At least 2 sessions.
talking about their adverse childhood experiences, talking about their current functioning, what's going on with you. You know, we talk about AODA, mental health, housing, PTSD, depression, stress, anxiety, protective factors as well, and resilience. So we kind of cover, if you look at the Wisconsin PCFA model, they really focus on why did these kids come into care and how do we get to the root causes of this so we can correct that and make sure the kids are safe so we can send them home as fast as possible. So a lot of families' experience in child welfare with that model is talking about the worst thing that ever happened or they ever did, or their worst experience in life for a good solid 2 months. And maybe not all of it, but one of the things that we want to help expand is taking this more holistic approach with families and engaging parents. And one of the things some people may think, and I think these guys have done a great job pointing this out in some of their work, is talking to families about these hard subjects is actually, they're into it. They want to talk about these things. They want to be heard. They want to be seen as whole people, not just the worst thing that they've ever been experiencing. And so we try, and one of the reasons we had these separate assessors do this is if you look at the work that many of you will be doing, the first 60 days of the case are insane. And we actually did a 6 Sigma analysis, which is like a business model analysis, look at time requirements of the first 60 days of a new case, and it's more than you can possibly do most times. So we also recognize in adding this well-being assessment that we can't just say case managers go do more. So that's one of the reasons we said let's have these separate people. It is one more person to touch a family, which can add stress and be a little bit confusing. But we also we have a motivational interviewing foundation for our work. So it's about partnering with both the family and the case management to identify priorities. So a lot of assessments can identify recommendations, as you're familiar with, or offer diagnosis. What the assessors really try to do is jointly identify priorities with the family and with the case managers. Because when you work with families in child welfare, I don't know if you remember a few years ago, Target was hacked and everybody lost their credit card numbers. Target knew they were being hacked as it was happening. They have a dashboard, but there was 1,000 red lights going on, and 3 of the blinking red lights meant they were being hacked and all their credit card information was being stolen. So it's the same way in child welfare. You get with a family, you can identify need upon need upon need, things that could possibly happen, but how do you actually get to the first 3 things that will have the most value, and what are the tools available to help you do that. So our assessors really look at engaging the family, listening to them, helping identify those priorities with the family and the case manager to bring all the best information you can to make the decision about what evidence-based interventions are available. And there's so many different kinds of evidence-based interventions there. It's hard to be an expert in them, which is one of the reasons we have our dedicated team, and they get clinical supervision from Dimitri, is to really think through. It's like, all right, is this family good for PCIT? Should they get trauma-focused cognitive behavioral therapy? Should they be in child-parent psychotherapy? Just to help bring that, recognizing again all the stress and where the case managers are at in those first 60 days. So here's all the stuff that we assess with the well-being assessments, and it really starts to give us a more robust picture both at an individual level and assisting case planning, but it also helps us have new insights and understanding parents that we never had this before. So how can we use this to look at a population differently and understand it from a systems point of view than we do not just the individuals. And of course, we understand our families by looking at ACEs. Our families have a far higher rate of having 4 or more ACEs than the original ACE study, but counting ACEs isn't enough. So when you look at adverse childhood experiences, there's no undoing an adverse childhood experience, right? So it's good. It's great context. It's important to understand the trauma history, but that's one thing that it doesn't necessarily mean you can undo it or do something different with it, but it provides that important context. And going through that survey, especially the one that Josh and Dimitri developed, really gives you an opportunity to listen to the parent and get a fuller picture of them as a person that they probably haven't experienced so far in that child welfare process. One of the other things that we look for with information, taking this to a kind of a policy perspective, is you can use all this information with data analytics to say, all right, what's going on at this population level that we maybe can do something different, and not just say case managers work harder or work different. So one of the things we asked we did a lot of research in developing, these guys helped in developing our well-being assessment process, and really what we found was, one of the things that we decided to add up front was asking questions about housing stability. And sure enough, it is actually work done by Mark Courtney and Steve McMurtry, when I think one of them that was here at least. And so when you look at housing, that's something that's talked about as a first line thing, and we're not supposed to take kids in for reasons of poverty, right? But 20% of the moms are homeless at the time they come into care. And one of the cases that came in recently where the mom was homeless, they had actually hit the child welfare system earlier, but they weren't so bad off and they weren't gotten to a shelter. Then they left. And then to hear the description and the change of what that 4-year-old girl, her functioning was like after they were picked up because they were camping in a park, to hear her being a bubbly 4-year-old in December and then reading the records about her in May or June, to see her affect being flat, being unresponsive for a 4-year-old little girl is just heartbreaking, because they weren't unsafe back in December. And child welfare is very much focused here about safety. It's about child protection, right? And there's some language in the CADS training that really highlights child protective services should be about child protection, which means some families sometimes don't get hit. Not every jurisdiction's, I'm sure even within the 72 counties, they're all different. But it's something to think about. It's like, how can we do stuff differently? How do we identify families in a different manner? And this data just kind of points to us, these families are having housing problems before they come into child welfare. So how do we start looking at our systems not as separate systems, but of one experience for the family? And so this is some of the work that we're working on now in terms of how do we, because case managers aren't in a position to change how they approach housing. This should be something that this provides an opportunity upstream, which is where we want to go with a lot of our work. How do we prevent families from coming into child welfare? So something to kind of think about when you do your work is, where are the systems that have touched this child before, and is there a possibility to identify these families up early before they get to our door, to keep them from coming into our door? So then we also have we also do parent-child action therapy at Children's. We do it with biological parents. We do Project Connect, the group-based adaptation from Josh and Dimitri, and then we also work with cases that are targeting adoption. And so they'll talk more eloquently about PCIT than I can. But one of the things that we want to do with PCIT in any intervention is measure success differently. So we're still working on this. This is not a perfect process. But the two primary scales that we use with PCIT look at changes of problem and intensity. So how much do the parents view, and correct me where I'm wrong on this, guys, how much do they view the problem behavior, and then how intensely do they experience the behavior? So we actually measure our kids, and when our PCIT practitioners do their work, they can see how their kids are doing relative to the norms. So we're looking at, like, were we successful with these PCIT cases based on changes in these function information like this, not whether or not they successfully completed the program, which is a different kind of thing. And being on the social work side, being on the practitioner side, we were very upfront with our folks about doing things differently this way. And it's stressful for people who are doing the clinical practice, because you can work really hard and families won't necessarily make the change that you hope to see. And does that mean, what does that mean for you? Does that mean you're a failure if we're looking at that change and, looking at families in terms of how they change in function or not? And it really doesn't, but we need to start challenging ourselves to look at changes in functioning, as opposed to, hey, I worked with a family for 2.5 years and I provided a non-evidence-based type of talk therapy, and they're maybe in the monitoring range of clinical, no longer clinical. So I mean, really, how do we want to define success? And that means challenging ourselves as clinicians, and challenging the clinicians to say, be more comfortable with not being perfect, right? It's instead of saying how many times did you see your family and were they successfully discharged, it's like, did they actually change? And guess what? You don't have control, all that much control over that. But at the same point in time, what do our families deserve? We need to know what works and what doesn't work with families. So this is one of the things that we're trying to do, is change how we measure things. And of course, Project Connect, we've been implementing this for a couple of years now. And you're going to learn and try to implement cool new things like Project Connect, and you will fail. Get used to it. Get used to it now. Get used to failure, and failure shouldn't be run away from. So our first 3 Project Connects, we were hearing, man, this went great. This was fantastic. Everybody gave us great feedback in our little forums, but the measurement didn't show that at all. And so then we came back and talked about it as a group and said, oh, hey, we're measuring this way wrong. And we adjusted how we measure things and to more accurately capture what we were doing. So, I mean, I think being open and understanding and looking at the information you have in your practice and being able to reflect and say, all right, do we have to do something different fundamentally? Do we have to tweak things? How do we do things to continuously improve? Because you will try things and it will not work, and you always have to kind of go reassess what to do next. So the well-being assessments and PCIT really kind of has been the foundation for the children's the program. Some of the programs Children's has brought to the Institute, and none of this would be possible if we were just operating in our practice silo without academic support. And as we look at, and as we came together as the Institute and really kind of saw the potential of using these learnings both from research and practice. I mean, they're both different kinds of evidence, but they're both evidence you can use to inform policy. How do we take that and move that forward? And policy doesn't have to be the big P federal policy level kind of intimidating thing. It can be, how do we change how we intake families into our parent-child interactions differently? Can we do that in a more trauma-informed way? There's different ways you can integrate evidence into the small interactions, which is probably where some of the biggest opportunities to do new things is in child welfare. How do you take this evidence and integrate it into your small everyday interactions? How do you change a placement of a child in a more evidence-based way? How can you in a more trauma-informed way? So how do you, and the systems aren't necessarily set up to support that right now, but how do you start thinking about, these small interactions on a day-to-day level that you'll do with children and families in a new way with the evidence you've learned? And the Institute, we've really tried to position the Institute realistically, but also as this place for translational work, where we can sit a couple different sides of the table and really kind of hash through, like, well, what about this? How do you look at this? And you will not have all the answers on your own, and don't try to. You will always be learning. I learn from these guys all the time. I learn from our policy people we work with. The continual learning is actually something to enjoy, and the partnering couldn't be more energizing. I've been the administrator who decides on what happens with children and families, and I've had to hire and fire and do all the not so fun stuff involved with leading a child welfare agency. But at the same point in time, finding that energy and partnering is the thing that gets you creative and gets that spark when you're further into your career to do the next different thing. That you can't, and this institute for me is one of those huge sparks that really has been energizing for me. And so in doing this, one of the things that I kind of want to, how am I doing on time?
40 minutes.
All right. So I'll skip the video. Check out the website. We have actually a video. The website is very purposeful. You would be shocked how much time you think about words and communication as a social worker leading a program. I wish I would have had a marketing class before I left school, because you actually have to figure out. We have a video about PCIT on our website. You can take a look at. That family was actually a family that was involved. We don't talk about what program they were involved in. We don't talk about, how do you talk about child welfare in a way that doesn't paint the parent as the evil monster? Mm-hmm. And that's really telling our story in child welfare is a huge thing nobody's cracked yet. Mm-hmm. But how do you talk about parents differently as opposed to the monster that we want to have to rescue the kids from? Mm-hmm. So that's something that we try to do with that PCIT video a little bit, is to kind of set forth like challenges and the benefits and telling a compelling family story without saying like this person's bad or leading off with these negative doom and gloom things. So communication, having these partnerships, and I'm still learning, and hopefully I will be till I'm done with this or they kick me out. But really kind of taking your time to think through and look at these other skills that you're going to need. I've written more grants in the past couple years, and I never took a grant writing class. Thankfully, Josh wrote one of the bigger ones. But writing, communications really is, not only important in terms of how you work with families, but how do you, communicate to people who aren't in the work? How do you communicate to people who make policy? How do you communicate to people who don't understand the nuance that you do? Is a huge thing that is a challenge for the field that we try to take on every day. So with that, I'll finally shut up.
All right. So let me just pause for a minute if I could, and just ask you all if you have any questions. Of course, as Gabe mentioned, we'll have some time reserved for questions at the end, but this might be a good time if you have a burning question to ask, whether it's about the Institute or more generally. I mean, you have someone here who has been in the field now for, I won't date you, but a number of years, and has worked at many different levels in direct practice and at different administrative levels. Do you all have any questions right now for Gabe before I get into some of my meat and potatoes?
Yeah. At what point during your direct practice did you determine I need to do something bigger, or I need to go to the next level?
I kept on getting frustrated with the people making the decisions and the decisions they are making. And you will experience the point, you're high achievers, you're in the 4E program, or you're people who are practicing in the field who took the time off to come listen to us. So clearly you're high achievers. But you guys are like, you're going to be in a position to maybe supervise people 2 to 4 years by the time after you graduate. There used to be a stat on that, I forgot what it was. But you're going to have that opportunity to go supervise people. And you're going to want to, because you are going to see practice that, God, I could help them do better. And man, why on earth did they make that decision? So I still make decisions. I'm sure people who work for me go like, why on earth did you make that decision? But it's one of those things where you start understanding how the sausage is made, and it's not pretty, and it's not as Ellen and I were talking a little bit about it. It's like some decisions are not as evidence informed as you would want them to be. It's like, why did you do that? Well, sometimes money got cut, and we got to do this, and there's all these like gross things that you don't want to have to deal with, and whether it's true, you're right or not, and whether I definitely have not always been right. You feel like you can contribute on that level, and you get frustrated by it. So.
Can I ask you a follow-up question?
Yeah.
So you're sitting at your desk and you're frustrated. What was your first step? Like, what did you do?
So
like move on to something bigger, more policy focused.
I started talking more. I started asking more questions in public, in broader context. So I didn't stay within my own little supervisor relationship. I started asking me questions at all staff meetings and other things to say, hey, what about this? And what about that? And then you start, I actually ended up in a training role first before moving into supervision. So kind of a leadership role. But that idea of like asking questions and being vocal and speaking up in settings that offer you a broader platform other than just work with the family or your supervision time.
Mm-hmm. Good question. Great question.
Yeah.
I know you said re-entry into the child welfare system was about 20%.
Yep.
So what point in like the well-being approach do you think we're failing families that they're not, is it like assessment, intervention, or are we not giving them services after their case closes, or? So
for my program, it was actually down to about 10-12%, by the way, just saying. When I was in charge. But when it's about using the information that you had. We started tracking years ago, looking at the information, and it's co-occurring disorders. It's parent mental health, parent drug and alcohol use, and then the parents struggling with the child's behavior. Those three things are by far the most prevalent factors that most kids aren't re-abused, by the way, when they come back into care. They're unsafe, and they're still open on orders. So they have that supervision in place, and so we pull them before they are maltreated again. So I mean, part of that is too having evidence-based supportive practices in place. If you think about, and there's always, I think, a friction, and I think Dimitri has probably some friction between AODA and child welfare because of relapse as part of recovery, and child welfare historically has been, you screwed up, we're taking your kids back. And I don't think that's completely been pushed out of child welfare yet. So, and judges make a lot of decisions, and it's about what level of risk are you willing to take as a child welfare agency, and the risk tolerance can swing dramatically depending on what happens. So you see the number of kids coming into care after a child death that makes the paper. You see the number of kids that go home, or those riskier permanencies slow down. So I mean, it's about risk tolerance and but also probably we need more models around supporting families through recovery and AODA and mental health and parenting that is more intensive at the right time. And there's been some efforts in Wisconsin that have shown some help, but nothing's really kind of clicked for us quite yet. So I think it's about having the evidence and the support. There's the new standards around, in Milwaukee we do post-permanency support, which there was a 4E waiver to take to some other counties around the state. But I don't think it's really had the impact that people have wanted it to. So part of it is, I think, a philosophical shift as much as it is a practice and having different tools to do it.
Thank you.
Mm-hmm.
All right, any other questions before I launch into my material? All right, hearing none. So today, first of all, I'm really grateful to be here back at my alma mater to talk with you today about some of the work that we're doing and some of the passions that drive our work. I have a pretty simple case to make today, which is that the children and families that we are all interested in helping. The reason we're all here today is that we share an interest in helping certain populations of children and families, right? That these children and these families represent some of the most disadvantaged children and families in our country, right? There are few families that face greater risks than the families that enter the child welfare system. And if we want to help them, and if we want to promote well-being, if we want to move this needle, I would argue that we have to do better. That we have to do better within the system and bring things into the system from outside the system, and forge partnerships between the system and other systems in order to move that needle. So I'm actually going to take a step back, if we could, and just talk about, okay, well, who is it that we're talking about here, right? These are things that you already know. I'm getting to preach to the choir today. So, but I wanted to talk a little bit about the families, the children and the families that enter into the system. So we know that there are a lot of cases that come into the Child Protective System each year. In 2014, there were roughly 3.6 million referrals, and there were 3.2 million unique children. So some are reported more than once. That's a lot of children, but only about 700,000 are actually substantiated as victims of maltreatment, right? But we know from the literature that actually the differences between children that receive an unsubstantiated report and those who are substantiated, that oftentimes they're not that different in terms of when you look at their outcomes. So this is a fairly large pool of children that we're talking about that are at risk, if you will, within our society. And then if you look at the deepest end, of course, that draws often the greatest attention from a child welfare system perspective, there are about 1,500 or so deaths on an annual basis, give or take, each year. And of course, that's a horrific outcome. And as Gabe suggested, it draws a lot of attention. And error management theory would dictate that child welfare systems have to prevent these things from happening, and so they're gonna focus on doing anything they can to prevent death from happening. And as a result, they may make some errors. In order to avoid the big error, they may make some smaller errors. They may be willing to trade the avoidance of the big error and in turn make a number of small errors. In any case, we also know that Child Protective Service data is really just the tip of the iceberg. When we're talking about the scope and the scale of adversity and trauma within our communities, within our population, these are the things that we see in a child welfare system above the surface, right? We know at the very tip we have those fatalities, this very small percentage of cases. Below that you have actual victims of maltreatment, right? 700,000 or so, and below that you have reports, and there are certainly a lot of reports that come into CPS each year. But below the surface, you could be thinking about within our population at any given time, there's actually a lot more adversity and trauma that actually exists than we're picking up with child welfare data, right? So Gabe has mentioned adverse childhood experiences. Are you all familiar with this theme of adverse childhood experiences? Great, fantastic, right? So it's this broader framework that includes not only maltreatment, right, abuse and neglect, but also includes other indicators of household dysfunction, as they say, right, family issues that can also have similar impacts as abuse and neglect. So there's a lot more ACEs in society than there are just substantiated or even reported abuse and neglect. But even down below the surface of that, we can think even broader, think, okay, not only is there a lot of adverse childhood experiences in our society, and research would suggest that over half of adults in the general population report experiencing at least one ACE, right? We can even go broader and think about social determinants of health, right? Not just these ACEs, but other factors that maybe mimic some of the effects of trauma, right? Poverty, wealth inequality, lack of access to good education, to good jobs, to good food, what have you, right? That also are associated with deleterious effects on children and families. And then if you wanted to go even broader and even deeper, we could start thinking about intergenerational and historical trauma, right? We know that these children that come into our system have been exposed to lots of risk, lots of abuse and neglect, adverse childhood experiences, social determinants of health, but potentially also they're at risk because their caregivers experience trauma themselves, and potentially their caregivers, right? And we're learning more and more within the field of sort of historical trauma about that history can repeat itself. And there's an emerging field of epigenetics. Maybe some of you have heard of this field of epigenetics. If you haven't, I really encourage you to find out a little bit more about it. We're beginning to understand more and more from the field of epigenetics about the causal mechanisms that may help to explain how history repeats itself, how trauma that occurs in your lifetime, how adversity that occurs in your lifetime can actually be perpetuated, and those effects can be passed along to your offspring and their offspring. It's a scary concept, but it's also there's a good thing about epigenetics, which is that if the needle moves one way, right? If things that happen in your life course can make you worse off, and those things can be passed along to your offspring, we as helping agents, as therapeutic agents, can help to move the needle in the other direction. And potentially the effects of our interventions as social workers, that we may not only be able to effectuate change on behalf of our clients, those changes could potentially be passed along to future generations, which is a more inspiring message, I think, from epigenetics. Okay, so what is an ACE? I think we all know this. It's a broader framework suggesting that we shouldn't just attend to abuse and neglect, like the 5 classic forms of abuse and neglect. We should also be thinking about broader indicators of household dysfunction, right? Substance abuse and mental illness that Gabe mentioned, these significant drivers of child welfare involvement, intimate partner violence, parental incarceration, being separated from a parent, right, because they were incarcerated or put in jail, divorce and separation. These are classic ACEs that are measured in the literature, these 10 indicators, what I call the terrible 10, right? There are some things we know about ACEs that we've learned from 20 years of research on adverse childhood experiences. First of all, ACEs are not rare events, right? Whereas CPS involvement is actually a somewhat rare event at a population level. ACEs are not rare. As I suggested before, study after study, you look at any population, you're going to find that more than half of the people in that study will report that they experienced at least one ACE. That being said, ACEs are particularly prevalent in certain communities, right? In economically disadvantaged communities and families, ACEs are really high, and the data that Gabe has illustrates that. We found that, say, compared to the statewide averages that have been reported through the Children's Trust Fund studies, we found that in their child welfare samples that when you look at, say, that 4 or more ACEs threshold, we're finding triple the rates that you find in the general population. That's not a surprise, right? We also know that these ACEs are interrelated, right? So people don't just often experience one ACE, they experience multiple ACEs, and that's a problem because the more ACEs you experience, the worse your outcomes tend to be. So ACEs are associated with a whole array of long-term consequences. You name your bad outcome, pick a bad outcome, you're going to find an association with ACEs, and you're going to find oftentimes a dose-response relationship. And that's a medical term, meaning that the more ACEs you experience, the worse your outcomes tend to be. It's sort of a linear model, right? And it's actually a hallmark of causality. It's a hallmark that what this pattern that you're seeing, that there's actually it's not just a correlation, it's not just an association, that there's probably something causal going on underneath. To illustrate, here's some data from the Adverse Childhood Experiences study, the study that launched 1,000 studies, right? Here's what they find, illustrating that dose-response relationship. What you can see quite clearly here is that the more ACEs that you experience, the greater your likelihood was of people in this study of reporting that they smoked, right? And here we don't have the actual outcomes here, but the one on the left is early initiation of smoking, and the one on the right is current smoking, right? regardless, you name your smoking outcome, you're going to find an association with ACEs. Okay, smoking's a pretty bad thing, I think. We can all agree. How about obesity? Again, another significant health problem. You can see, again, that same kind of association. Dose response, ladder-like sequence. The more ACEs you experience, the more likely you were to be obese later in life. And these were, in this sample, we're talking about individuals who average 57 years of age, right? Heart disease. They also found this huge whopping association, particularly at the tail end. When you had a lot of ACEs, boy, you were at great risk of heart disease. Now, why do I show these three outcomes to a group of child welfare professionals? There's no real good reason for that, other than it's really cool information. The point I want to make here, though, is that when I'll ask you, let me pause here. What do these things have in common? Why am I showing smoking, obesity, and heart disease together? It's not because it's pertinent necessarily to child welfare practice, but what do those three outcomes have in common? Smoking and obesity, heart disease. Smoking and obesity, heart disease. Why? Why am I showing those? Please.
I would guess that they're, to some extent, stress-induced.
They're stress-induced, absolutely. What are smoking and obesity, heart disease? Why am I showing them? Spit it out.
And obesity cause heart disease.
Smoking and obesity cause heart disease. And lo and behold, look, we see that we can track those outcomes back to adverse childhood experiences. This problem, heart disease, that manifests typically in your 40s, 50s, 60s, 70s, and 80s, right? We can trace those to experiences that occurred early in the life course, right? Toxic stress, early adversity in the life course. And we also know, right? And a lot of the ACE research is focused on these later life outcomes. Well, we're often working with children, much younger. You're not going to see heart disease, typically speaking, in a 5-year-old or in a 10-year-old. But we also know from a lot of good research that we can actually trace those later life outcomes, disease, dysfunction, death. We can trace them back to experiences in early childhood, and we know that there are really good causal reasons. There are causal mechanisms that explain that. As Gabe mentioned before, we know that early adversity and toxic stress has neurobiological effects, that it literally undermines brain development, that children who are exposed to lots of stress, lots of adversity, they literally have a poverty of brain connections. Right? It actually undermines the very foundation of how your brain develops. And it also then has implications for your cognitive development as well as your social emotional functioning, many of the outcomes that we are concerned with when we're talking about child well-being. Okay, let me pause there for a second and before I move on. Questions? That's the warm-up. Questions? Hearing none. Okay, Gabe kind of touched on this earlier. So we're making the case that I think we should be attending not only to the effects of adversity and trauma, but that actually in order to attend them, we actually need to ask these questions. This needs to be a part of routine practice in many settings. But and it's becoming less and less common, but often when we are in community-based settings and we do a lot of outreach with many different partners, we still occasionally run into questions about whether or not I, as a social worker or some other helping professional, whether I should be asking these kinds of sensitive questions. They are sensitive questions, right? And there are some really good reasons for that, right? I mean, you're trying to oftentimes build a strong rapport with a client or with a family. And so, there's some concern naturally about, well, if I ask these questions, am I going to turn them off? Am I going to scare them away? Am I going to trigger some kind of trauma that they may have experienced and actually do some harm by asking these questions, what we like to call in the field iatrogenic effects, right? Like doctor-induced harm, literally. You don't want to do that, right? And so these concerns are well taken, and they come, I think, largely from a good place of wanting to do no harm and wanting to do the best for families. That being said, study after study after study that has investigated this issue of whether or not we should be asking about early adversity, whether we should be asking about a person's history of trauma, has shown that actually the vast majority of clients, the vast majority of people can tolerate these questions quite well, right? That very rarely do clients just decompensate, which is like a big fear that social workers often have, that like if I ask these questions, they're gonna start crying and they're gonna be inconsolable and there's gonna be a breach between us that I'm never gonna be able to repair. That very rarely happens in our experience and in as the literature would suggest. So we're making the case, and Gabe made this earlier, that we should be asking about these questions oftentimes. It's not always appropriate in every setting, right? And it's very important how the questions are asked and when they're asked, absolutely. But as I said before, the vast majority of clients can actually respond to these questions. They can tolerate the questions. Not only that, people who report discomfort, reporting discomfort is not necessarily a bad thing. Some degree of discomfort is not necessarily counter to therapeutic principles. And actually, the clients who report discomfort, the literature would suggest, they actually also report at the same time that they were glad that you asked, right? That it's actually important to be asked these questions. And Gabe's experience sort of reinforces that they're finding that actually clients often want to be asked these kinds of questions. They want to be heard, right? And actually, there's this risk on the other end of the spectrum, right? Which is that, okay, the concern about asking these questions is well taken, but what happens if we don't ask? What if you don't ask these questions? What are the risks there? Is the trauma not going to be there if you don't ask it? Right? No, of course not, right? It's always going to be that elephant in the room, right? And there's this other risk that potentially we may be overemphasizing our family's vulnerabilities and underestimating their resilience, right? And for us, we talk about this a lot, how there's this natural pivot point. When you ask about ACEs, it actually leads to a natural pivot towards strengths-based practice, right? Because you can communicate in that moment that, wow, you've experienced a lot of adversity in your life course, right? And look where you are. You're made it here today. You've survived, right? And you're still, fighting for a better life. So choose your own words. And you'll come up with more eloquent words than I just did. But it actually does make a nice transition to strengths-based practice. So Dimitri and I have done a lot of work in this area around adverse childhood experiences. And back in 2012, we developed a tool, the Childhood Experiences Survey, that tried to push the envelope a little bit. When we're thinking about adverse childhood experiences, it's a great framework, it's a useful framework, and it helps to broaden our lens a little bit beyond abuse and neglect. But it also has some limitations. There are potentially some things that framework is missing that we're not capturing, right? So if we go back to what ACEs are, right, it adds in these indicators of household dysfunction, but those aren't the only indicators potentially of adversity that may affect our families. We know, for example, that poverty matters, right? Particularly extreme poverty and other associated correlates like homelessness. Gabe talked a lot about housing challenges, right? We know from the evidence that not only are these things risk factors, they actually have consequences that mimic some of the same consequences as abuse and neglect. In fact, there's some really cool research coming out of UW-Madison that Seth Pollack and his colleagues have done here, where they have looked at the trajectories of children who are at various socioeconomic levels, and they've shown that the effects of poverty, poverty alone can undermine brain development early in the life course. That if you look at children, say beginning at 4 months of age, and then you track them over time, by 36 months of age, you see this divergence, significant divergence, depending on whether you're high SES, middle SES, or low SES, right? So just strictly poverty alone can have these significant impacts. So we added questions about these in our measure. We also added questions about death of a parent or sibling, which can be a salient experience. We also asked a question about prolonged parental absence. Now, why did we do that? Well, the original ACE measures asked about divorce or separation. Really important thing to be asking about, right? I'm a child of divorce. I can attest to its impacts. That being said, many of our children don't come from families where their parents were married, right? And if you only ask a question about divorce or separation, you're potentially missing, again, salient experiences that that have happened to these children. And so we ask about the effects of having a parent that was out of your life, at least one or more parents being out of your life for a long period of time, right? So you could be thinking again about parental incarceration or having a caregiver who just was out of the picture, right? We also ask questions about peer victimization and violent crime victimization. Why did we do that? Well, most of the original, in fact, all of the original ACE indicators are designed to capture risk within a household setting, abuse and neglect and household dysfunction. But is that the only source of adversity, right? Put on your ecological systems lens, right? No, we know that a lot of adversity occurs outside the household, right? And so we wanted to ask about things like bullying, severe peer victimization, as well as violent crime, to capture stress that occurs outside the household. And so we have integrated this tool into home visiting services throughout the state, as well as at Children's Hospital Wisconsin Community Services. And we're very thankful for that. And we think that this represents, again, just a small step forward toward understanding where our families have coming from. So I want to now shift gears a little bit. And I want to also be respectful of time for Dimitri.
Okay.
The main event. So we know that there's lots of adversity in our society at large, but we also know that children who enter the child welfare system have experienced the most, typically speaking, right? And I think that this sets us up. I think that the ACE framework, if it does nothing else, I think it maybe doesn't make the best practice argument necessarily, although it does have practice implications that we may get to, but I think it makes a compelling policy argument, right, to people outside of the child welfare system for why we should be directing resources to these children and to these families. And in particular, today, I want to make the case for early intervention, why we should be moving the needle by moving upstream, if you will, and trying to focus more of our resources toward prevention and early intervention to the extent that we can with our limited resources in child welfare, right? So these children, these families, they've been exposed to lots of stress, lots of adversity, etc., and so it's no surprise that the children who enter the child welfare system are at high risk of emotional and behavioral disorders, right? You see it on a daily basis in your system. It's estimated that up to 80% of children placed in foster care present with emotional and behavioral disruptions, okay? Estimates vary depending on how you measure things or what have you. But suffice it to say, it's going to be the most common things that you see in the field, right, is emotional and behavioral dysregulation, and it's a major driver of challenges and of costs in the child welfare system. Why do, for example, children disrupt why do placements get disrupted? Oftentimes it's because substitute caregivers have great challenges in managing difficult mental health and emotional behavioral presentations, right? Unfortunately, so here's these children who really need the best of what we can offer as a society in terms of best practice, best prevention and intervention. But unfortunately, validated treatments are often unavailable, or even when they are available, they're inaccessible to these families. And it's especially true for young children. There is a poverty, there's a dearth of high-quality services for young children at large, but particularly in the child welfare system. And this is a problem. This is a big problem because if you don't intervene early, the research tells us, and common sense tells us, right, that you're going to pay for it later, right? That it's a pay now or pay later kind of thing, and that if you don't intervene early, these early disturbances tend to, not always, but they tend to grow worse over time, and they become more difficult to treat later on in the life course, and they're major cost drivers, right? If you don't pay for it up front, they tend to lead, on average, to more challenging problem presentations that are more difficult to adjust or mitigate later on in the life course. And we also know from a broad literature on early childhood intervention that it makes sense to intervene early in the life course. This is something I like to show. It's called the Heckman curve. So James Heckman is a Nobel Prize winning economist at the University of Chicago. He's done a lot of work with folks here actually in Wisconsin at the University of Madison, Wisconsin-Madison. And his work has demonstrated quite clearly, and this curve demonstrates that the earlier that you intervene in the life course on average, and these are broad estimates, not only the more effective that your interventions tend to be, but the greater return on investment you tend to have. You know, in fact, if you look at these later life interventions, so you take, for example, job training interventions, good interventions in some respects. In fact, Dimitri and I are doing some work in that area, and so I don't want to come across as bashing job training by any means. But if you look at the literature, it would suggest that at best, those interventions return $1 for every $1 invested. Right? They're break even from a cost benefit standpoint. You talk about early childhood interventions like say enriched preschool programs, high quality preschool programs, you're talking anywhere from $3 to $7 for every dollar invested, right? So it pays to intervene early. That's my case. In child welfare, it pays to intervene early in part because who's coming into the system, right? The vast majority of reports, right, are front loaded. Right? You can see the huge numbers that come in actually during infancy and toddlerhood, right? We need to be getting to these families earlier, right? Another point I want to make, right, which is that, and this is a good note, is we need to be intervening early because we actually know how to intervene early. It'd be one thing if the case was that, oh, we know that these young children present with problems, right? And that a lot of children are coming into our system who are very young, but we don't really know what to do with them. Well, that's just simply not the case. We actually have the technology, right, to intervene early. There is no shortage of high quality, well-validated early childhood interventions that are specifically designed to address the challenges that these young children present with. Gabe mentioned a few of them. I'll revisit them here. Trauma-focused cognitive behavioral therapy, TFCBT. Very few interventions have been better validated to address some of the problem presentations that traumatized children present with. We mentioned PCIT. Dimitri's going to be talking about that at length. PCIT is part of a broader tree, a broader family of parent management training interventions. And so while we are working with PCIT, we don't want to be dogmatic about this and say, oh, it's PCIT, that's the way you should be going. There are other interventions that draw from these parent management training intervention principles. These are bedrock principles that have been proven in many different models and across dozens and dozens of randomized trials to be very efficacious in addressing particularly emotional and behavioral problems in young children. And then you also have child-parent psychotherapy, which is a slightly different flavor, and it draws more so on psychodynamic and attachment principles, and it's been shown to be efficacious with infants and toddlers. Now, Gabe mentioned PCIT. I'll be very brief here, but I just want to set the table for Dimitri and just reinforce the point that this is an evidence-based treatment for children, particularly between the ages of 2 through 7, who have externalizing symptoms. What are externalizing symptoms? These are things like aggression, acting out, tantruming, attention deficit hyperactivity disorder, right? These are things you see a lot of in the child welfare system. So this is a particularly appropriate type of approach for the child welfare system. It also so happens that this model has not only been validated in clinical trials, it's been validated in multiple randomized trials and many other studies with families in the child welfare system, biological parents as well as substitute care providers, right, including some of the research that we have done. It works, right, and it works with this specific population. And it works because it has really good principles, really good active ingredients, including psychoeducation, which you're going to find in most therapeutic models. It also emphasizes live parent coaching with children, so not just teaching parents or teaching caregivers what they have to do in a didactic way, actually showing them and having them implement it in vivo, right, live in the moment. engaging in modeling and role play, important ingredients, and also using assessment to tailor treatment, right? To mark progress as people move along and so that we can adjust. I'm going to pause here in my presentation and go back to this whole theme of assessment, and I'm going to get up on my soapbox, if I may, and make an appeal for the importance of assessment. As Gabe mentioned before, in child welfare, we gather lots of data, and Gabe's team gathers lots of data, right, in particular, right? And there's a lot of things you can do with this information. There's a lot of reasons to be doing assessment. One approach, it's a good rationale, is assessment provides us information, right, for a system. Particularly for a system that likes to document its compliance. Are we doing what we're supposed to do, right, so that we don't get in trouble, and so that we also, in a good way, are accountable, right? We're accountable as a system. That's a good thing. We want to be accountable. In addition to that, I would argue that assessment is important because it informs our practice. As any experienced social worker will tell you, as Rosemary would tell you, there's few tools, I think, that we can have that's more important when we're working with a family than a case history. Knowing where someone comes from. That's about as important a tool as you could possibly have, right? Ongoing assessment, not just at baseline, but ongoing assessment also helps us to track client progress or family progress over time, right? So we can track their well-being over time. It's really good for that reason, and it also helps us potentially, if we're not able to meet their needs, to refer families to appropriate services elsewhere. But I'm here to make the case that assessment is not just something that you do to inform practice. It's not just something that an initial assessment worker does and to hand off to somebody else, right? Assessment itself is practice. There's good evidence to suggest that part of what drives the effects of an intervention is not just the intervention itself, it's actually the assessment process. Simply asking people questions, particularly if you're good at it and you do it in a therapeutic, empathetic way that demonstrates unconditional positive regard. If you're really good at that, it can actually drive your assessment effects. Somewhere on the order, estimates would suggest up to 15% of an intervention's effects are captured just within that assessment process. Okay, back to where I was, off my soapbox. So we have all this knowledge, I think, and we have all these technologies that are really useful and could be really useful, particularly for children and families in the child welfare system. But there's a lot of barriers out there to getting them into the system, some of which Gabe mentioned. Federal policy is one of them, right? Social Security Act, Title IV-E money, vast majority of child welfare funding, more than 90%, it comes through Title IV-E, right, which pays for things like foster care subsidies and independent living arrangements and child welfare training. Yay, child welfare training. All really good stuff, right? Only about 8% comes from Title IV-B, which programs like Gabe's can actually use that are flexible funds that you can use toward prevention and intervention services to work with families, right? And the Families First Act, that's pending legislation. Hopefully you all are somewhat familiar with that legislation. Contact your representatives about it as it moves through. Yeah, contact your senator. Yeah. So contact Senator Johnson about this, right? Hopefully we'll make funds more flexible so that more funds could be directed toward prevention and intervention. Also a shortage of mental health professionals. We've already mentioned that before, particularly in the early childhood. There's also often a mismatch between these models that, eggheads like us tend to focus on. We develop these cool little mousetraps, right? These clinical models that are really good in highly controlled settings, but may not fit well. They may not match well with how services are delivered in the real world. We have to be thinking about that. In addition, these models, they cost money. It costs money to pay mental health professionals. It costs money to deliver high-quality therapeutic services, right? A lot of these models last a really long time, and you may not always have a family for that long, and even if you do, who's going to pay? It's not Title IV-B, so who's going to pay, right? So this is what we have spent a lot of our time thinking about, is how to bridge this gap, how to address these gaps between what we know and what we do. And we think that translational work I don't even like to call it translational research. I like to call it translational work because that puts sort of research first. Translational work, translating between these areas of program design and implementation, translating between that research and evaluation as well as policy advocacy, right? That can hopefully help to shrink this gap that exists, right? Figuring out how to implement the best practices, the best interventions under real-world conditions, and hopefully, again, helping to accelerate that process from discovery to implementation, right? It's been estimated in other fields, like the medical fields, that it takes anywhere upwards of to 17 years for a discovery to actually reach the marketplace. And so what we're trying to do is, again, not only shrink that gap, but also shrink the time that it takes to move really good, these goods and services, right, into the marketplace. A few final notes, and then I'll pass it on to Dimitri. This is really difficult work. And I don't say that to uphold us as like some kind of martyrs, right? As though, oh, we're engaged in this really just arduous work, that no one else is willing to do. But it is. It's tough work. It would be much easier, frankly, for me to sit at my computer, pull down a secondary data set from somewhere, run some analyses, some computer models, and spit out papers. It's a lot easier. It's fun, too, by the way, for someone like me. But doing this kind of work, forming strong partnerships in the community is not easy. It takes time. It takes effort, right? You have to put yourself out there again and again and again, and you have to sustain them, right? Relationships, any kind of relationship, it takes maintenance. It takes effort. So that's one key process when we're thinking about translating evidence-based practices into child welfare, and Gabe spoke to this, right? Bridging that gap requires, I think, not requires, but it's best done within the context of an academic community partnership, right? Bringing together what we know from policy as well as research that tends to filter, at least to some degree, through the research world, as well as what we know from evidence and experience in practice and in the field. Bringing those things together, it's not easy, but it's important. Second thing to point out, and this somewhat reflects a way that I think we approach things a little differently maybe than is typical, particularly on the research side of the ledger, is that when Dimitri and I are thinking about, okay, what is that we want to do? What do we geek out on, right? Like, where do ideas come from or what have you? A lot of times in traditional research approaches, you start with your curiosities and you start with theory, and those are great places to start with. And then we build mousetraps and we test them out under conditions that we can control, right? What we try to do, though, is we try to balance that with an analysis of what's going on in the real world, right? What is it that Gabe needs? What is it that his system needs? How does it actually operate? How does it actually function? And then we work our way back, and we identify, potentially based on that scan, areas in which child welfare practice is not functioning optimally. Maybe there are some gaps that exist, and then we try to identify potentially practices or interventions that we can use, right, and insert into those services as usual, right? So rather than asking a system to adapt to a model or adapt to some kind of evidence-based practice, we reverse it, right? And we think about how does the system operate, how does it function, and then what models exist, what practices exist that we could insert in those, right? We also think about cost and sustainability. While we're doing that, you should do that from the beginning. But when we do this, when we engage in this process and doing this analysis of sort of goodness of fit, we're also thinking about, okay, oftentimes we have to adapt those models. We have to be willing to be somewhat creative and to adapt evidence-based practices so that they fit. But you need to do so carefully and cautiously. You need to be careful about just mixing and matching and just willy-nilly changing things because it feels good in your gut, right? Or things just don't fit, but we want to do this, and so we just think this is going to work better this way, right? You need to attend, I think, again, I mentioned this term earlier, to the active ingredients of a model. So we can modify some things. Maybe we can modify the location in which an intervention is delivered, right, or the mode in which it's delivered. but you don't want to mess around too much with the core ingredients of the model. Dimitri's going to talk a little bit more about some of the core ingredients of PCIT, right? And not only when you're developing the model or developing the intervention or developing the strategy or what have you, or the approach, but sustaining that, maintaining that fidelity to those active ingredients over time. It's something that's really important because it affects the benefits, right? It affects whether or not that model is going to actually really be effective. And we saw that with the Project Connect findings before, right? That fidelity to the assessment process as well as to the actual model itself, it matters in terms of actual outcomes. Okay, that's all I've got for now. Maybe I could take one burning question if there are any in the audience. Otherwise, I'd like to turn it over to Dimitri. Please. Okay, please. Yes.
Is Milwaukee County the only one doing this PCIT work that's moving to this model?
So there are some shoots that are beginning to bud up in other areas. For the most part, PCIT is primarily being done in Milwaukee. There are some initial interest, I know, in Waukesha, I believe, right? And I believe there's one other provider somewhere in the western part of the state. Do you know? But not a lot. Thanks. Yeah, great question. Nope, needs to be more of stuff like this. Other questions? All right. Hearing none, I'm very proud to turn the microphone over to my friend and colleague, Dimitri Topitzes.
No, I can see.
Who is, again, the Director of Clinical Services in the Institute, and he's going to talk more about PCIT and some of our translational work.
Absolutely. So before I do so, though, I want to just take the temperature. Do we need to take a quick little break? I notice people are starting to walk and we can go to the restroom. Do you want to take a quick 5-minute break and then we can resume at 11:35? Want to just what would you like to do? What's your preference? Okay, let's take a quick break and then we'll resume at 11:35. Okay, we're ready to start. So once again, thank you to Ellen for inviting us. Thank you all for your attention. My name is Dimitri Topitzes, as Gabe and Josh have referenced. And I'm going to talk a little bit about how our partnership, the partnership between Children's Hospital of Wisconsin and University of Wisconsin-Milwaukee, essentially Gabe, Josh, myself, and our colleagues, how the partnership is manifested in several different practices that we're currently implementing. So you've heard reference to all these different practices, the assessment protocol that is being implemented within Children's currently, along with a TFCBT implementation project, so trauma-focused cognitive behavioral therapy. I'll talk briefly about that. Josh and Gabe both referenced it as a highly validated clinical intervention that is initially meant for children who present with sexual abuse, but has also now been implemented or delivered with children and their families who have experienced other forms of trauma. And at Children's, we have a TFCBT learning collaborative or clinical group that is implementing this project while also in training in a very, very unique, in my estimation, a very unique model where we're implementing a highly validated, evidence-based, trauma-focused or trauma-informed intervention within a strict child welfare setting and using interns as well as clinicians in training to do so. And I'll also talk at some length about our parent-child interaction therapy learning collaborative. So these are ways in which our institute, our collaborative, is actually putting into practice this kind of translational work, as everyone has been sort of referencing. And I'll try to conclude with some basic themes, and I'll be relatively brief in nature, and we'll end by a little bit before 12 and hopefully take some more of your questions. And I believe we're also going to share a meal with each other. I was going to talk briefly about my background, but I'm going to pass on that because Ellen did such a gracious job of doing so. Only to say this, that my interest has been, along with Gabe's and Josh's, has been to sort of work at the nexus between practice and research, or research and practice, so that I can contribute to this movement whereby practice informs research and research informs practice, so that what we're doing on the research end is much more relevant for what we're doing on the practice end, and we ultimately can together best benefit the families that are at high risk of intergenerational trauma, which are the families that we work with, describes the families we work with. I won't describe that, we've already discussed that. I'm going to jump right into the work we do with this assessment group that Gabe discussed at great length already. This is a very busy slide. I'm not going to outline, I'm not going to dive in in great detail. Suffice it to say that we have approximately 4 or 5 now clinicians, along with several different interns, that are implementing this evidence-informed multi-generational assessment process with families who are entering the child welfare system. The clinicians that are conducting these assessments spend a great deal of time, a good deal of time, I would say, with the families, with the children, and as Gabe mentioned, with the parents, at least 5 hours in time. And actually, oftentimes they spend at least 2 different sessions talking with the families and implementing these well-validated assessment protocols. As mentioned previously, we implement these or administer these assessments early in the service episode, so clearly the findings can actually affect or influence ongoing service plans, and we assess for multiple domains. Gabe already outlined them. I don't need to repeat them. A point that I do want to emphasize, though, is we use a motivational approach when implementing these assessments. So parents who have contact with the child welfare system oftentimes come with sort of different experiences and attitudes, none of which, I would argue, are necessarily really amenable to deep engagement with the system. They oftentimes tend to have not the most promising experiences or positive experiences with the system, and they come with sometimes very low levels of motivation, what we oftentimes call pre-contemplative stages of change. They're not really interested in changing their behavior. They're interested in having their children reunified. So it makes great sense that we would use a well-validated approach, a system of assessing and intervening with these families that has been shown to work well with families that are unmotivated or non-voluntary, involuntary clients. Motivational assessment or motivational interviewing, who's familiar with this approach? Great. Those of you who are familiar with it know that it's a marvelous and an elegant system, a very difficult system to master. Would you all agree with me on that? It's really cool. It's based essentially on 5 different common elements or micro practices. Good open-ended questions, nice reflection, good summarization, and on and on. And yet to be able to sort of weave those together in a masterful way can be challenging and fun at the same time. So we talk at length in our assessment group supervision meetings or consultation sessions about how to actually implement this approach with some level of skill and acuity, and it's great. We enjoy this process. So we embed our assessment process within a motivational context, and we parlay the results that we glean into our recommended service plans. And the assessors have the opportunity to then share these recommendations in what are called, correct me if I'm wrong, priority meetings, where they meet with the family sometimes, but also with the case managers and case manager supervisors to share with them not just the assessment results, but also recommendations that might emerge from those results. So we talk at length in our assessment consultation groups about how do we engage with the families. We do a great deal of case review. How do we engage with these families, which can be a very challenging prospect. So these are families that within the first 60 days are sort of reeling from oftentimes the removal of their children from their care. They bring a lot of frustration and perhaps some biases to the assessment process. So there's a big hill to climb, if you will. So we talk at great length about what strategies we might use to engage families and draw on motivational principles, draw on various evidence-informed practices, but also draw on our own creativity. I think a great example of what Josh and Gabe were mentioning previously. How do we bring together evidence but also local practice in a way that's going to benefit our families? Because what's the most important evidence Is the research the most important evidence? Absolutely not. What's the most important evidence? What's happening in the moment with our families? Are they responding to what we're doing? That is, according to a particular approach, the most important evidence that we have to attend to. So are our families engaging? Regardless if we're staying true to motivational principles, are our families really engaging with our assessment process? So we talk at great length and sort of brainstorm creative solutions to quote-unquote non-voluntary, quote-unquote, resistant families. We talk about our assessment results, and as I mentioned earlier, we sort of generate recommendations together, and we also have there's a great deal of excitement and enthusiasm when we are thinking about how we can parlay or translate these assessment findings for each individual family at the local level into a good service plan that our ongoing case managers will honor and our families will potentially buy into. And we have several different evidence-based practices that we can offer, and we have different ways of offering those practices, as Josh mentioned, adapting them for various local contingencies or exigencies. Okay, that's the please, question.
Would you say where you conduct the assessment in family homes?
We do it wherever we can. So we will go to where the children and the families are, and that will include for children in the foster care settings, perhaps in the group home settings, perhaps even at school. With the parents, we will meet them in the jails. Some are incarcerated. We will meet them in their homes. We will meet them at the agency if they prefer. So we're very, very flexible in that regard, which I think is a strength of the assessment process. Great question. So that's the assessment process. If you have any questions, don't hesitate to jump in and ask those questions. How about the TFCBT, Trauma-Focused Cognitive Behavioral Therapy Learning Community and consultation group that we have running now? We have a set, I think, upwards to 10 clinicians in children's that are part of this collaborative. We've all just recently received our initial TFCBT training through Jennifer McGaughey, who's a clinician here in Madison, actually, and she's sort of slated as the TFCBT guru here in Wisconsin. So she came to Milwaukee, and by virtue of a grant through Community Advocates, was able to train a number of clinicians, 10 of whom were children's based. And we continue to receive ongoing consultation from Jennifer. In between our consultation meetings with Jennifer, we also have what we call our learning collaborative meetings that I sort of facilitate, but a number of us participate in at Children's. What is TFCBT? Real briefly, many of you heard of it, about it, I assume. Fantastic. So it's a very well-validated model, as Josh mentioned. It's trauma-focused. What does that mean? Does anyone want to take a stab at what trauma-focused means? It's actually a technical term. It's somewhat hackneyed. We use this term a lot, but it has a real technical meaning. Does anyone want to take a stab at it? It's not a quiz. It's just an offering.
Getting set up.
Yeah, getting set up. No. Oh, you're smart. Okay, good. Good. It actually means it's an intervention that doesn't just target the effects of trauma, like, for instance, emotion dysregulation, attention dysregulation, behavior dysregulation. It does that, but it also addresses or targets the memories of trauma and helps to resolve those trauma memories through two different means, through two different, as Josh mentioned, active ingredients. What are those? One, gradual exposure. We talk about the trauma, even if it appears that we're working with a child, even if it appears that the child isn't ready to talk about the trauma, we discuss the trauma, we sort of identify it in sort of bite-sized pieces, and then we address the trauma through what's called the trauma narrative. And this is meant to, at least in the parlance of trauma-focused cognitive behavioral therapy theory, it's meant to desensitize the child to their experience of trauma and help them sort of reprocess and integrate their memories of trauma. And research shows that this is one of the critical or active ingredients of the intervention. It's a two-generation intervention. It isn't only focused on the child, it also includes the adult or the parent, which I think all of us, the three of us and perhaps all of us in this room would agree is optimal when working with children because that's ecologically valid. The children obviously function within the context of a family system, and so helping the family system change, not just the child change, is what's going to ultimately result in generalizable improvements over time, or sustainable improvements over time. It's a phase-based intervention, and many trauma-focused, well-validated trauma-focused interventions are phase-based. meaning we pay significant attention to a sequential intervention phases. Children and families must graduate from one phase before they get to the next phase in order to assure not just fidelity to the model, but in order to ensure this sort of developmental process of healing or therapeutic change over time. It's been noted that we resolve trauma, generally speaking, in a sort of cumulative way. We have to feel safe. We have to feel as if we can manage ourselves, then we can resolve our trauma, and then we can generalize those changes to our environments. And that is a common phase-based sort of sequence of trauma-focused interventions. The phases follow this acronym, PRACTICE. Just briefly mention what they are: psychoeducation, relaxation. Children are taught these different skills: affect regulation and cognitive coping. They're taught those 4 PRAC skills, they're called. Then we go into the trauma narrative. We do some in vivo work so that the children resolve their, not just their memories of trauma, but also their reactivity to trauma cues. That's what the in vivo work is all about. Conjoint sessions is the next C. In other words, this is where the dyadic work really takes root. Parents come and they listen to their children, or caregivers come and listen to their children review their trauma narrative. Can you imagine how powerful that is? If a child is able to share their experience of the trauma, and it could even be a trauma that that parent perpetrated, and the parent just receives it with a great deal of openness. It's incredibly therapeutic. And then enhancing safety, in other words, generalizing any change so the child has, and the parent has, ongoing protective capacities. This is a semi-structured intervention. Meaning that the phases are outlined, and yet there's a good deal of room for clinical judgment when delivering each of these phases, which in one way is really exciting. So clinicians feel as if they have a lot of latitude to bring themselves and their skills and their training and their intuition and their judgment, et cetera, to these different phases. At the same time, it can be somewhat daunting for new practitioners and clinicians in training. And so we do a good deal of time. We spend a good deal of time in our TFCBT consult groups discussing case progress, where are clinicians at in the different phases, what are the choices that they're making, and we do this not to be somewhat authoritarian or imperial in nature, but instead to provide good support for those who are sort of clinicians in training and new to the model. We talk a good deal about the progress of the children. There's a principle attached to this intervention called minimal mastery. Has anybody heard of that? It's an interesting concept, and I'm still trying to sort of accept it, wrap my mind around it. It simply means that the child is considered at mastery. In other words, they graduate from any one phase when they are able to implement whatever skill is being taught at that phase one time in their environment. And then initially I didn't like that very much, and I still am trying to wrap my mind around it. But once a child reaches minimal mastery, then they move on to the next phase. The theory behind it is that the child doesn't necessarily have to completely master the task at hand. Instead, they have to generate or develop some competence, and really where we want to get this child to is to that trauma narrative, so that they can then resolve the trauma memories. And that's where they'll actually be able to really accelerate their progress in the model. We talk at length about, I'm going to skip to bullet point number 3. In our collaborative meetings, in our consultation groups, we talk at length about who is really well suited to make progress in this model. What clients are suitable for this model? There's been some research to suggest that TFCBT is probably appropriate for approximately 30 to 50% of families in child welfare. So while a number of families may be referred in-house from case managers to our clinical team, and they may fit our inclusionary criteria for the model, and there are only a few of them. There are age ranges, and there's an identified index trauma, and the caregiver, whoever's involved, accepts that index trauma took place. that doesn't necessarily mean that that family is gonna, or that child is going to respond well to services. So early in our service delivery, we'll talk at great length about who's responding well and who is not. And there are plenty of referrals, and that we have sort of the luxury of moving maybe a couple sessions into the model and talking with clients and saying, well, perhaps this isn't the right time if they aren't necessarily engaged. And we have great conversations about that. We talk at length about the toll that this work takes on providers, talking about trauma, sometimes talking about trauma when children aren't really excited about talking about it, developing children's skills whose skill development might be very arrested. It can be really, really challenging work. And particularly working with clients who aren't really ready for the intervention, and trying to figure out when it's time to cut bait. That can be really challenging work and can take its toll on interventionists. At the same time,
Sorry.
yeah.
I just wanted to.
Oh, there's a question.
Oh, I'm sorry.
Oh, I was rolling.
I know, I'm sorry. What is the age range?
That's a great question. So if I'm not mistaken, the model has been validated for ages like 3 to 18. I have really significant questions about delivering a model that is cognitive-based to 3-year-olds. So generally speaking, we work with 6 or 7-year-olds as sort of the minimum age range. And at Children's, there is a grant to work with adolescents. So we really focus our attention on ages 12 to 17, 18. Thank you. Good question.
Great question.
Yep. Where was I? So we talk about the toll that delivering the model, particularly when we're sort of new in our understanding of the model and clinicians are new in their practice of clinical work. But we also talk about the excitement that seeing progress in the model generates, and it really does create a lot of enthusiasm in these clinicians in training. So that's TFCBT. Other questions about TFCBT? We're only about 4 months into our practice of TFCBT, but it's going quite well. I haven't seen the data, but from a clinical standpoint, it's going quite well, and I've really, I can say from my vantage point, really enjoyed interacting with clinicians and doing the kind of work that is really translational in nature. And what is that? It's staying true to the active ingredients of the model, but then honoring the exigencies and contingencies of the families with whom we're working, the clinicians that are actually implementing the model, and the setting in which it's being implemented. So we do take liberties to adjust the model as we see fit, while again at the same time staying true to those active ingredients. Yes, another question to throw me off my.
Yes.
Please.
What is the average time that it would take?
Great question. So great question.
If anybody has it?
Yeah. So the model has the typical duration for implementing the model according to the evidence is something on the order of 12 to 18 sessions. However, when implementing it within child welfare, there's some, I wouldn't say published evidence, but there's some anecdotal evidence to suggest that it really should take at least 30 sessions. So we are sort of gearing ourselves toward about a 30-session service episode. And so that is that's a good 6 to 8 months. And that makes sense to me because these are really complexly traumatized children and family systems that, as Gabe mentioned so astutely, family systems that are really as multi-problems as it comes. So we're 30 weeks, 30 sessions. Yes.
Is the model only a dyad model, or is it also applicable to groups of siblings or to a whole family?
That's a great question. So there's really it's primarily focused on one child, but we have not been afraid to open up the caregiver involvement to two or more caregivers. But if we're working with more than one child, then we're starting a whole new service episode. So one service episode should be focused on one child. Now, we certainly can work with siblings, but we would consider that two separate service episodes, if you would. But we certainly are opening up the caregiver involvement to more than one caregiver, and that's been kind of exciting. And I'd love to do some work around that. I hope that answered your question, Rosemary.
Yes. So my question was whether the model itself allows one to work with more than one child simultaneously.
No. So no, and not in a. Again, we would consider that two separate sort of episodes. So certainly we can do it, but we would not consider that one service episode. Certainly we can do it though. So I can work with two different siblings, even work with them at the same time, and even work with the same parent who might affiliate with this, or who will work with this child and work with this other child. But I would consider that, as a consultant and supervisor, as 2 separate service episodes. I hope that made sense. And 2 different clinicians can actually do that work, or the same clinician, but it's separate work in essence. We wouldn't want to bring those children together. Why? Because children might have similar experiences, but interpret those experiences very, very differently. And we want them to have their own sort of separate trauma narrative, and share with us their different interpretations of their similar experiences of trauma. So it really should be individualized to the child. Does that make sense? I hope that made sense. Okay, good. Parent-child interaction therapy, and I'll end here. Just another few more minutes. This is where our partnership really started. The PCIT work that Josh and I did, and then Gabe graciously opened his doors to partner with us and implement PCIT in a way that was not just evidence-based, but also quite translational in nature. And as Gabe has said, it's been really beneficial to Children's to be able to partner with us, because hopefully we bring some insights from the research. But for us, it's so beneficial to partner with Gabe, because now we have a real-world setting where we can share our ideas and test our ideas, and hopefully together really improve family functioning. So I won't talk at great length about our PCIT collaborative. We've been actually in operation for a good 2 to 3 years. Parent-child interaction therapy. We've been trained by one of the best international trainers here in Milwaukee. Her name is Cheryl McNeil. She operates out of West Virginia University, and considered a master trainer. Was one of the initial disciples of the model developer, and she has graciously come to Milwaukee twice to train us. She has overseen training that I've conducted, and she continues to consult with us during our ongoing learning collaboratives. What is parent-child interaction therapy? It's again a phase-based intervention, evidence-based, trauma-informed. It includes 2 different phases: child-directed interaction, that enhances the child-parent bond, and then parent-directed interaction, which improves child management skills and improves child self-regulation skills. As Josh mentioned, there are a number of different modalities, or a number of different ingredients of the intervention. The coaching is the most important ingredient. We coach the parent while they're interacting with the child, and we enhance their bonding and parent management skills. We have a number of different ways, I'm not going to go through it, that we implement this intervention within Children's, and we've taken a lot of liberties and used a lot of sort of taking creative license to adapt this model. We screen parents who are eligible for the model, so that we're not working with parents who are actively involved in aorta issues and not receiving any treatment. If they're actively involved but receiving treatment, we'll work with them. If they have active mental health issues but aren't receiving treatment, we can't work with them. But if they are being treated, then we do work with them. Active IPV and not working on that issue, then it's hard to implement parent-child interaction therapy. And then we also assess for motivation, the most important sort of, in my estimation, the most important sort of prerequisite for involvement. During our consults, our PCIT group consults, we review cases at length. We talk about really interesting clinical challenges that people are facing. Why aren't they making progress? And we are working with, by the way, again, like the most incredibly challenging families, from my estimation. They bring with them a number of different challenges, and as Josh mentioned, intergenerational challenges. And we're teaching them state-of-the-art parenting practices. And we're not just teaching foster parents these skills, or adoptive parents, but we're teaching bio parents these skills. And what I can say anecdotally, and I think what Gabe can say based on his data, is that these parents and their children are making progress. Children are reducing their externalizing behaviors, and also reducing their internalizing behaviors, and parents are using some really state-of-the-art and impressive parent management skills, along with parent bonding skills. And we talk at great length about a lot of the parents will get stuck, particularly the birth parents, and we'll talk at great length about how to work through that. It's a really interesting point. I'll also mention real briefly, and then we'll end. We also talk at length about how to sell parent-child interaction therapy. And one of the hallmarks of parent-child PCIT is a timeout procedure during the parent management component. And there are a lot of people, maybe some people in the room, have concerns about implementing timeout procedures with children who've been multiply traumatized. Does anybody have that concern? And this timeout procedure actually isolates the child in a room. Now, we're in the room with the child, but it does include some isolation. Now, there are different schools of thought, but we talk at great length about how to justify that sort of work, which has shown to be, by the way, quite evidentiary. How do we justify that type of work within a trauma-informed framework? Some people argue that we're re-traumatizing the child. I completely disagree. Wholeheartedly disagree. We are introducing the child to what I would argue is a necessary trauma trigger. And then we're teaching that child how to regulate themselves through this necessary trauma trigger. What child doesn't need to learn how to accept discipline and internalize that discipline? Without that skill, without that self-regulatory skill, there's good research here at UW-Madison to suggest that life course prospects are significantly impaired. So these are the kinds of conversations we have in our learning collaborative, and I find them quite fun because they're evidence-informed and yet they're practice-relevant. And this, I think, is a hallmark of the translational research that we do. That's it. I will stop there. I will stop there, and I apologize. I was 1 minute over, but it was a pleasure speaking with you all. Thank you for your attention.
Thank you very much for your time today. That was really interesting. I think I'd like to offer that maybe if folks, I want to be respectful of people's time, and I know some people have appointments to get to, but I think you can stick around for a few minutes before we move on to the next thing to answer any questions that you might have. So thank you very much for coming.
Thank you for having us.